Good afternoon, everyone. We're waiting for a bunch of people to log in right now. We should be getting started very shortly. Good afternoon, everyone, and thank you for joining us for our virtual event today, checking in on the Medicare and Social Security trust funds. Today, we'll be exploring the status of the trust funds with the trustees report coming out yesterday. This is perfect timing. We'll be hearing from a panel of experts on potential policy options to extend their solvency, and they will be taking questions. So be sure to use that Q&A function in your Zoom window to make your voice heard. But first, we will have a short presentation from Committee Senior Vice President and Senior Policy Director, Marc Goldwein.
Thanks, Chris. Hello, everyone. Happy day after Trustees Report Day to all who celebrate. Chris, can you just confirm for me that we have the right slides in my queue?
You are all set.
Great. So again, thank you everyone for being here. The Committee for Responsible Federal Budget really does celebrate Trustees Day. It's one of our favorite days because we get to put out not one, but two different papers. If you check out our website, crfp.org, you'll see an analysis of the Social Security Trustees Report and another analysis of the Medicare Trustees Report. And so if you want to learn about what's in these reports in 7 pages instead of, I forget, 150 pages each, definitely check out our website. I do want to go over that pretty quickly what we have found. So not surprisingly, both Social Security and Medicare are in some significant financial trouble. They're both within about a dozen years of insolvency. Under these latest projections, the Social Security Old Age Program will be insolvent, will run out of reserves by 2033. That's just 9 years from today. The disability program, fortunately, is in much stronger shape. And if politicians were to reallocate money between the two, we can make it to 2035. Again, still just 11 years from now. The Hospital Insurance Trust Fund for Medicare Part A will run out of reserves just a year later in 2036. Now, these insolvencies are a result of growing imbalances for both programs. Social Security in particular is seeing costs continue to grow as the population ages, well in excess of revenue, which is pretty flat. By 2035, the gap's going to be enough to necessitate essentially a 17% benefit cut upon insolvency. It would be 21% if just for the old age program. And you can see from this graph that gap is going to continue to grow thereafter to almost 5% of taxable payroll at peak. Medicare is in somewhat better shape, Medicare Part A, but its costs, thanks to rising health costs and aging population, are going to grow over the next few decades well faster than revenue, leaving a pretty large gap that peaks at about 15% of costs. The trustees have an alternative scenario in which costs you can see grow much more rapidly over the long run, but under current law, because of very tight provider payments, eventually 75 years in the future, they think that costs and revenue will get back into line. Turning back to Social Security for a minute, this shortfall estimated over 75 years is about 3.5% of payroll, which is roughly 20% of benefits. So to give you a sense of the size of adjustment you need to reduce all future benefits for current and new retirees by about 20%, or raise all taxes by, from 12.5% up to 16%. And that would at least get you to that 75-year mark. The longer you wait to address Social Security, the trustees show, the larger the adjustments need to be. As an example, you could solve all this today with a 21% cut for new beneficiaries. It'd be 25% if you wait a decade. For new beneficiaries only, it'd be literally impossible. And similar story in the revenue side. We can raise all taxes by 27% now, or 32% if we wait. Turning back to Medicare, and again, this is all these papers are on our website right now in a lot more detail. But turning back to Medicare, what we see is that actually all parts of Medicare are growing, but especially Medicare Part B. And so right now costs are about 4% of 3.5% of GDP. They're headed to 6.5%, maybe 8.5% under that alternative scenario. I do want to kind of close by saying that things have improved relative to last year. That's mainly due to stronger near-term economic growth and some other factors, lower disability, et cetera. But even though they've improved, we've also lost a year. And so overall, we're in a similarly precarious situation, and time is running out to solve this, to address these trust funds and this significant spending growth. Hopefully, our politicians will come together and come up with solutions to Social Security and Medicare. A good starting point would be to have some public trustees, because these trustees reports currently are being written only by administrative officials, even though the law says there should be 2 public trustees. There are nominees that have made it through the Senate Finance Committee, but not yet been approved. So it's certainly something I think we can all get behind. But at this point, assuming Congress isn't going to do that in the next few minutes, we have a panel of experts that I think can talk about this in a lot more detail. So please join me in welcoming our panel. First off, from Harvard Medical School, we have Michael Chernew, who's a professor of health policy there. From the vice president of health policy at the Center for American Progress, we have Andrea Ducas. We have a Social Security expert who was formerly at the Congressional Research Service and SSA, Laura Haltzel. She's also doing some consulting with CRFB right now, and we're happy to have her on board for the interim. And lastly, Jason Fichtner is the chief economist from the Bipartisan Policy Center. So please welcome panelists. I'm going to get started in just a second, but for those of you watching at home, please submit questions through the Q&A function. We're going to be asking them throughout, and I'll try to synthesize your questions and make sure that they get answered in some form, if possible. Let's start with Michael and just the basics. What did we learn from yesterday's Medicare trustees report?
Well, the big headline number, I guess, is the 2036 number for the Part A trust fund got pushed back. My general view about that, by the way, is I wouldn't put that much stock in the trust fund number per se. I think the bigger issue with Medicare is just the overall burden that the program is placing on the economy. And of course, as you mentioned, Part B is growing very quickly, and that's not really part of the trust fund calculation. But anyway, the point is, if you're focused on solvency, it did get pushed back some, and in part, as you said, because of better revenue, in part because of slower growth. So that's thing one. Thing two, I think that the report highlights, and you showed this in your slides, Marc, that the gap between the illustrative alternative scenario and the current law scenario really grows. And we really need to think through what and how we are going to manage the program. I think the current law scenario, as is pointed out in the report, raises a number of challenges moving ahead, and that I'm not sure the illustrative alternative scenario is the numbers that I would have picked, but I think they illustrate importantly that we're going to have to probably put more money into the Medicare program than current law would suggest.
Thank you so much. Andrea, dig a little bit deeper for us. What does this report tell us about the overall sustainability about Medicare and where where the flashpoints are in the program or in the programs?
Yeah, sure. Thank you so much. I guess I would take the opportunity to say, I think this demonstrates the urgency around acting and going after sources of unnecessary spending. And, I would say one of the areas that we've elevated at CAP is the high level of overpayment to Medicare Advantage plans, which are now, representative of just over 50% of the program. And I'm looking forward to talking through this in greater detail, but did an analysis that built off of some of the estimates in the most recent MedPAC report about the level of overpayment, and think it's actually somewhere between 22 and just about 40% worth of overpayment. So that's a number that in 2024, if we were to go with a higher estimate, would be around $127 billion of excess spending that could be reined in, and importantly, and really critically, reinvested in the traditional Medicare program. So we walk through estimates around the contributors associated with risk coding and selection bias, and have a number of recommendations around that, but also think about the subsidizing effects that components of MA, like the quality bonus and county adjustment system, contribute, with arguably delivering marginal value at best. And then also think that there's some opportunities that to improve the way that the traditional Medicare benchmark is calculated, to account for the fact that so many people now on traditional Medicare have supplemental coverage, which facilitates increased use of services. So you don't really necessarily have an apples to apples comparison when you're looking at an MA bid compared to the traditional Medicare benchmark. So when I look at this, I just see opportunity to make some different investment choices. It definitely, underscores to me the urgency around that action, not only with respect to solvency and sustainability, but also with respect to, solving for problems that beneficiaries are experiencing today.
Thanks, and I'll just give another plug for CRFP that under our Health Savings Initiative, we've done a lot of work on looking at those Medicare Advantage overpayments. So check out our website. Let's turn back to Social Security for a minute, and Laura, I'm going to start with you. What did we learn from today's report, and what's changed relative to, say, last year, or relative even to 10, 15 years ago?
Sure. So similar to what Michael pointed out, we have had a gain in a year when you combine there's actually two trust funds for Social Security, which I think a lot of people may not know that legally the OASI program, the Old Age Survivors Insurance Program, and the Disability Insurance Program are separate. And so even though the numbers are provided separately, we frequently talk about them as a joint program for Social Security. So on a joint basis, we gained a year compared to last year's report, moving out to 2035 as the new projected year of insolvency. The other thing is that we're looking at the payable amount being a little higher compared to previous report, at 83% payable at the time of the program trust funds depletion. So those, I think, are good signs. And as Michael had pointed out, there's a mix of reasons behind why we have a little bit of good news here. Some of it's economic. We saw an increase in economic growth compared to what the trustees had projected for the years through 2023. And so that has helped us along the way. We've also had some changes in the demographic assumptions. And those have worked in a mixed way. So while we have had some benefit due to a reduced expectation in the prevalence of disability insurance, which is great because it means that we're paying out less from the trust funds in terms of disability insurance, it also means that those are workers that are not out of the workforce. They're contributing to the workforce while they are not disabled. So that is a double bonus, really, for the Social Security trust funds. But on the other hand, we had a decline in the fertility assumptions or the birth rate, whereas previously we had expected 2 children per woman in the United States of childbearing age. They have reduced that down to 1.9. But not only that, they have moved up the period for when that change happens by 16 years. So 16 years of a lower birth rate has a negative effect on the trust funds because there are fewer workers in the future that are paying payroll taxes into the system. So those are at a very high level, some of the biggest changes that we saw. But I think it's sort of amazing how little from year to year really does change. Every year since basically 2012, the trustees have predicted that the insolvency date would be between 2033 and 2035. And here we are again with 2035. So that has not changed. The actuarial deficit, really has not shifted that much. We've gone down to 1 point, I guess by 0.11 from 3.61 last year to 3.5 this year. And as a measure of GDP, the Social Security costs gap is still at about 1.2. It was 1.3 last year. Overall, not a whole lot of shifting, mostly demographic and some economic.
Thanks. So something that has changed since 2012 is 12 years have passed, right? Jason, tell us some of the bad news. What are the challenges and the costs of having waited so long and of continuing to wait?
Well, I want to, first of all, thank you for having me on today. It's good to be here with all of you and for all of those that are participating and listening in. I want to kick off on something Laura mentioned because it was one of the 3 things I wanted to get across. And one is the importance of the depletion date and when the trust funds are depleted, especially for OASI, which now is 2033. That's the same as last year, but that is within a 10-year window. Like, we are getting to the point where we have to do something. We've had to do something for years. And the longer we wait, the harder it gets and the bigger the magnitude. So Laura mentioned looking back at the last few years of trust funds. Let me expand that a little bit, because we always sort of get asked, in some years the projected date gets changed by a year, sometimes a few years, sometimes not at all. What should we read into this? And it's worth noting that while the date has varied quite a bit in recent years, depending on the assumptions used in the reports, think about the last 30 years of trustees reports. So 30 years, from 95 to 2024. The date of trust fund exhaustion or depletion has ranged between 2029 and 2042. We are now at 2033. We have been for the last year. The closer we get to that depletion date, the easier it is in some ways to make the prediction because you have less time in which things could change on a variable. So we basically, unless something changes more with the economy rapidly or dramatically, we're going to have trust fund depletion in the next 10 years. And this means that waiting only makes those necessary changes larger, regardless of whether we focus on tax changes, benefit changes, or some are offering now, we want to basically use general revenues. But keep in mind, general revenues means borrowing money. So what has changed in the last 12 years is the net present value of unfunded liability. So we now have a $34 trillion national debt right now, $34 trillion. The Social Security unfunded liability is about $22 or $23 trillion. That's on a net present value basis, meaning if you wanted to make the program solvent over 75 years, you'd have to put that $22 trillion in the bank today. That's a lot of borrowing. And as Michael mentioned, we are probably going to have to do more funding out of general revenues, i.e. borrowing for Medicare. So this is going to create an issue of 2 importances to notice. One is that it's going to create additional stress on our finances, including our interest rates and the debt and how much we're paying on interest, which is already approaching $1 trillion a year. And 2, it's going to crowd out our ability fiscally to fund other priorities we have, whether it's education, paid family leave, additional medical, or even increasing Social Security benefits. So that's one of the important things. And the last thing I'll say before turning it back over to you is DI. So the Disability Insurance Trust Fund is now solvent throughout the 75 years, a slight surplus at the end. The size of the trust fund is small compared to the OASI trust fund. And it is very, very sensitive to economic conditions. So Laura mentioned that the prevalence rate of DI is down. I think since 2014, we've seen less people applying and less people projected that are going on the program. If we have a major recession, those numbers are going to change rapidly. There are people who are at the margin able to work, but they're the first ones who sort of apply for disability when they find those jobs are no longer accommodating for them in a recession. we could see a major change in trust fund depletion if we hit a recession for the DI program. So I don't think we should say that DI is fine when we're out of the woods. We need to keep an eye on it because, again, basically 1 year of DI, the trust fund basically, as you see right now, only gives you about 1 year of 1 to 2 years of OASI funding. So if we moved all that money in, and that's if Congress, doesn't do anything. But the programs are separate. Laura mentioned this as well. The trust funds are two legally separate trust funds. We have to do something. If we wait until 2033, it could be a 4 percentage point increase in the tax rate for OSDI, excuse me. That's actually, people might say it's 4 cents on the dollar. So why should we worry about it? But you can see how this framing goes. You could have those in the left saying for 4 cents on the dollar, you can fix Social Security, and those in the right saying, hey, it's a 32% tax increase. Both of those are correct, but the framing is going to be different. And that's why the challenges get harder the closer we get the trust fund depletion date.
Thanks, Jason. I want to dig a little bit deeper on these healthcare numbers because we've seen actually over the last dozen years a continued slowdown in the rate of growth of healthcare beyond what we expected. Almost every trustees report has had the numbers lower than the previous one. This report in particular, it seems like all the savings are in Medicare Part A. Part B and D are in fact a little bit worse off over the very long run. But overall, we've seen it in all parts of Medicare. So I want to ask both Michael and Andrea why, but I want to combine this with a few other questions I'm seeing in the queue. And so I'm going to ask you, can you talk a bit about in the why, what effect, if any, alternative payment models are having, or you think they're having? What effect, if any, you think Medicare Advantage is having? And then lastly, particularly this year, how much are people shifting from inpatient to outpatient? And is that affecting the distribution between the between the various letters of the alphabet? Michael, let's start with you, and then we'll do Andrea.
I'm happy to start. I was hoping Andrea was going to go first and give the right answers. Maybe she'll correct me. I think all of that is true. Two things. It's hard enough to forecast Medicare spending. It's particularly hard to forecast which part of the program things are going to begin. And as your question pointed out, Mark, they are connected. If people shift from inpatient to outpatient, that moves you from A to B, for example. And there's a lot of nuance into how that plays out as to why. So that's clearly a factor, and it's important as to why that's happening. I think there's a number of things that are going on. Some of it, and I think an important thing is there's just medical technology. We can do things now that we couldn't do before, and there's just been a long run decline. No, there's been a general decline in the need for inpatient care relative to outpatient care. So I think that's one factor that's going on. I think some of this is mediated by the incentives in the system. So people mentioned Medicare Advantage and alternative payment models. I actually think both have some spillover effects. We need to do a better job of quantifying them because they do help push to the lower cost setting. I think the issue there is probably more a Medicare Advantage than alternative payment model impact simply because of the scale of the Medicare Advantage program relative to, say, the ACO programs, but I think they're pushing in the same direction. I might add to that, it's not just inpatient to outpatient, but it's also how we use post-acute care, which comes up also in how nursing home is used versus home care. So I do think there's a lot of efficiencies that are hard to forecast that are coming out. I think to some extent, actually, you also see some drug offsets that are going on. So better chronic care management can help shift between the different programs. So I think the answer, maybe I should have been briefer and just said yes. All of that's going on. I don't think we have particularly good estimates, not only say how much is the spillover versus medical technology. So that's one. I wish I knew the answer. I'll look for the chat. People will give me the answer. So I don't have particularly good estimates of that. And even more importantly, I don't know how that would change with minor changes. I'm hoping by the time we get to the end of this, you'll ask more about Medicare Advantage, which Andrea raised. But in any case, I don't know how small changes would affect that spillover per se. And I think that's almost the more important question.
Yeah, I don't have that much to add. I think that was a great answer. I mean, there's a lot of prognosticating about why we've seen that slowdown. And I think anybody who gives you one answer to that question might be a little overzealous in their response. We really don't know. With respect to APMs, I mean, I think there's been some mixed evidence of what they've been able to accomplish, but it's sort of impossible to tease any one thing out. But I suspect probably a lot of that has to do with what we're able to accomplish, as Michael shared, in outpatient settings, in less intensive settings, improve chronic disease management. I think that's likely spot on, but it's sort of impossible to distill it. And yeah, looking forward to having a discussion about the trade-offs associated with some of the, care management and utilization techniques that might be leveraged, especially heavily by Medicare Advantage plans, and what that means not only for spending, but also for the beneficiary experience. But thanks for the questions.
Okay, turning back to Social Security, although this affects Medicare too, but when it comes to Social Security's payments, a huge part of the story is how many workers have, how many people are paying into the program in the first place. So I want to ask both Laura and Jason, how much, sort of two questions, which again pull in some things from the Q&A, but first, how much the recent surge in immigration improve things, and how much would further expansion of immigration help or not help? And then a similar question, I'll throw that one to Laura, then the similar question to Jason, which is, how much would delayed retirement, people stay in the workforce longer, improve Social Security's finances, and how much has it maybe improved it already? So Laura, I'll ask you about immigration, and Jason about older workers.
Sure, thanks. Well, first I want to start off by saying I read your piece that you posted ridiculously fast after the TR dropped yesterday. And I agree very much with your points that revenues are failing to keep up with costs, and that the rising costs are mostly due to the aging of the Social Security population and the American population overall. That's not due to some large increase in benefits. This is very much a demographic issue. And so you have two demographic answers, potentially: increasing birth rates, which unfortunately, given a lot of the work that the trustees have done on this, does not look like that is going to be an improving area for some time. The other being immigration. Absolutely, immigration can and should be a part of what the solution is. There are countries like Canada that have opened up immigration as an option to help improve the number of workers in the population relative to the number of retirees. Because last time I checked, even if we started today, having children more than expected, it takes 20 years for them to become a productive worker. No way to accelerate that process. So immigration in the near term, I think, is going to have to be part of that solution. Obviously, legal immigration is going to be preferred. I know that there are frequently concerns about illegal immigrants that will come in and will work and steal benefits. One thing that people frequently don't understand about people who may be working without papers, without documentation, is that they frequently adopt the same Social Security number to work: 000000000. And so what this means is, at the end of the day, they literally cannot collect on those Social Security covered earnings because they can't identify their earnings from everybody else that's using a not fake Social Security number. So we actually end up benefiting in a very unfortunate way from illegal immigration, because they end up contributing through the payroll tax to the trust funds, and then at the end of the day are not able to actually receive those benefits.
Let me add something on this, Marc. So the issue when it comes to work is very important. And so the question you asked me, I want to answer differently. You asked me about how does continuing to work affect the trust funds. So first, because I've seen some in the chat, let's make sure we get sort of language straight. When we talk about the trust funds going insolvent or the trust funds being depleted, it does not mean the program itself is going bankrupt. That is not what we're talking about. The program will still be there. The point is, under current law, the program can only pay out in benefits what it collects in revenues, which by 2033 is payroll taxes. And that's enough to cover roughly 79 or 80% of benefits. So the program will still be there. The question is in what format. And what's important for everyone to understand is that by law, we can't just raise, Social Security can't raise taxes. Social Security can't borrow money. Its only option at that point, if Congress doesn't do anything, would be to cut benefits to match outlays with revenue flow. So it's important we're talking about trust fund depletion and what that means to the program. And when you think about working, so I think work has to be part of the question, but the program is generally designed to be actuarially neutral, meaning whether you claim benefits at 62 and get them for a longer period of time at a lower monthly amount, or wait till age 70, get a higher monthly amount, live to the average year, on average, you should come out the same on a net present value basis. So the idea of working longer is more talking about what that means for your income, your personal health, your wealth, your satisfaction. What affects the trust funds is whether or not we move the retirement age and make the retirement age later, because that would have an impact on the trust funds. What we have now, though, is because we have waited. We talked about the idea that we've known this is coming for over 30 years. Because we've waited, sort of the one-on options are gone. So when I was at Social Security as the deputy commissioner and chief economist, and I worked and signed 3 of these reports, back then when President Obama was president, we could have just raised the taxable maximum and gotten rid of it, like eliminated the taxable maximum, and that would have given us 75-year solvency. Now we can't do that. Now we've got to do that and payroll tax increases or reduce the retirement age. It's got to be some combination. We've lost our one and done policy options. And the longer we wait, the more that's going to happen, the more we're going to impact people who really need this program. So that's why I want to get back to the importance of doing something today, because we've already waited too long, and the cost of delay will be even greater and actually impact those who will be most adversely impacted by this potential changes going forward.
Thanks. Let's pivot and talk about solutions a little bit. And Michael, since you just asked me to ask you about Medicare Advantage, I'm going to go ahead and do that. And why don't you tell us a little about what we can do in Medicare Advantage and how that might affect Part A solvency versus how it might affect spending on the other parts of Medicare?
So again, Andrea, I'm happy to do this. I did ask that. Andrea, you haven't gone first. If you want to go first, I know you raised this in your intro. Okay, then I'm going to jump in. A few things. First of all, I do believe that Medicare Advantage is paid more than the beneficiaries would spend if they were in fee-for-service. I think that reflects a number of things that Andrea mentioned. It reflects coding, it reflects selection, it reflects the quality bonus program. Some of it reflects blatant policy choices like 115% in a quarter of the counties. The benchmark's 115% higher in a quarter of than fee-for-service and a quarter of the counties intentionally. I don't label that overpayment, by the way. It is just higher payment. I don't label it excess payment. It is just higher payment in fee-for-service. That higher payment funds better benefits. Someone asked why people join. The benefits are so much more lucrative than you would get if you were in fee-for-service. And so a lot of this is trying to titrate how much we want to spend and how much extra benefits we want, and understanding if we cut Medicare Advantage, what would we lose? Because the plans will adjust in a number of ways. My general view is for modest cuts, you wouldn't lose that much. And to give folks some idea, the rebate, which is a measure of the gap between Medicare Advantage spending and fee-for-service spending, and it goes back to the plans which they use to finance these extra benefits. That rebate has gone up double, triple, depending on when you start. We're now at like $190, whereas before we could have been, 70, 80, depending on what year you look at. So there's a lot more generosity of the benefits now. I don't want to downplay how much Medicare beneficiaries they get lower Part D premiums, they get less cost sharing, lower deductibles, all those things. My general view is with modest cuts, you won't lose a lot of that because the plans will adjust. And so we need to titrate into the level of added benefits we want in the Medicare Advantage program. And some subset of people, I think Andrea mentioned this, would like to use that to rebalance the programs. How that gets split across Part A and Part B in the trust fund is, again, complicated because it gets allocated. And the allocation depends on the A-B ratios and stuff like that. I don't view the policies related to Medicare Advantage is fundamentally focused on the trust fund per se. It will help. I view it as more a Part A trust fund. I view it as more related to the overall fiscal burden that Medicare has on the economy. And I believe that there is certainly room to cut. And the question is the pace and our ability, if we wanted to fund more generous benefits, whether we should do that through the Medicare Advantage program, whether it's a mechanism to do that, or whether we should find other ways to do that that some might think are more efficient. And that's a complicated calculation.
Thanks. And Andrea, you and your colleagues have sort of a comprehensive plan to address Medicare. Do you want to, give us a short summary of that, and what do you think are the most promising elements?
Yeah, sure. And just to zoom out a bit, I can share why I think we view the enhanced or extra payments as a measure of an overpayment versus just additional monies. I think as Michael sort of indicated, and maybe I would put a finer point on, I think this is just sort of a larger values question and how we think about how we finance the program writ large, and agree that it's not just a conversation about how you allocate across Part A or Part B, and you look at the trust fund. But I think it's there's a bigger societal question. But in general, or related to that, if we were spending all of this money on Medicare Advantage, and the Medicare Advantage program was delivering demonstrably better quality and a demonstrably better patient experience, that would be one thing, but there's no real evidence that it is. And when you look at the uptake of supplemental benefits like dental care, like vision, we're not really seeing much of a difference in terms of what beneficiaries are actually accessing. And there are a number of questions there. In part, it's because we don't really have great data, but also I think that it's probably an indication of how generous these benefits actually are, how wide the networks are, et cetera. I think a challenge with the MA program and talking about policy changes associated with MA generally is that it can be a pretty heterogeneous experience depending on where you are in the country. And I have questions about the extent to which the choice beneficiaries are making are because of a thought that one product is superior, or because for a lot of moderate to low income Medicare beneficiaries, it's not really a choice. Like if you can't afford to go into traditional Medicare and buy a supplement, buy Medigap policy, and you don't qualify for additional coverage, you might not have an alternative. Like if you're looking at an expensive premium or a set of premiums and you're comparing it to something that's $0, it's sort of a de facto choice that's made for you, which is why I think it's important to look for opportunities to do that kind of rebalancing so that you're actually creating a meaningful choice for all beneficiaries, not just for higher income beneficiaries. But to the point around the plan, think that there's a lot more that can be done to address the upcoding and risk score sort of gaming that we see in MA. And we talk about the importance of excluding chart reviews and health risk assessments from risk scores, stopping, percentage of premium contracts, improving the coding intensity adjustment that's already applied, doing a lot more around auditing to have that be done more in real time, and ideally have that financed by the MA plans, and then looking at different ways of approaching risk adjusting. We think there should be a correction factor applied to account for selection bias, although it's interesting to think about how selection bias may be changing in light of what I just shared about the choice people are making. I think at a minimum, the quality bonus and county adjustment programs could be made budget neutral. They're not now, and that's not consistent with the way that we approach other pay for performance programs. And then again, looking at how we consider what goes into the traditional Medicare benchmark. And then the general premise that we come to this from the perspective of is that Medicare shouldn't be paying MA more than it would cost under traditional Medicare to provide the benefits to the same benefits to the enrollee. And a way that we think we can accomplish that is by not only applying some of the recommendations that we've made to change the way the traditional benchmark is calculated so that it's more accurate, and then introduce a competitive bidding process so that you've got plans bidding against that improved benchmark and you're paying whichever of the two is lower. So that's how we approach it. But we think it's really important to be linking those fixes to an improved traditional Medicare program. One, to level the playing field, and two, to ensure that you've got parity across the program, that everyone has the opportunity to make a meaningful choice, and that we are investing in a coverage and insurance system that we think, we owe to American seniors.
Thanks. So turning back to Social Security, Jason, costs of the program have risen pretty dramatically. For example, as a percent of payroll, they were 11% prior to the pandemic. Now they're 14, they're headed to 18. What are some options on the cost side? A couple of kind of the most promising things we could do that would slow the growth or reduce the cost of Social Security.
I think it's important. Maybe we'll talk again. We'll have Laura talk about revenues, and we should come back to this. But I think people should think about this as a cafeteria menu on both revenues and benefits and the cost side. So, putting it all out there, one is thinking about the cost of living adjustment, the COLA. We could change it from CPI to a chain-weighted CPI or a chain-weighted CPIE, which is experimental, but for the elderly. So thinking about how we do the cost of living. We could, of course, change the retirement age, which if we raise that out to 69 or 70, would mean that it'd be a lower benefit for those at age 62, the reduction factors. We need to think about how that interacts for those who can't work past 62. We could change the benefits for family members, how we do spousal benefits. We also could think about other ways of doing this on the cost side. But generally what you're looking at for costs is you're changing the benefits themselves. So reducing it for higher income workers, reduce some of the benefits for everybody, or changing in some ways the benefits that are paid for family members, or changing the cost of living. Those are kind of the main things. Retirement age, that's in the bucket we have to work with right now on the cost side.
And Laura, what about on the revenue side? We've got a lot of commenters asking about raising the taxable maximum or raising the payroll tax rate. What are sort of the viability of those options? And are there any other things out there that are not in that standard mix?
Yeah, so I think I want to echo a little bit something that Andrea raised, which is some of this boils down to what are our values. And I think it's really important to remember that Social Security was put in place because there was a need. And so when we are talking about making changes to the program, it's not that we think Social Security benefits particularly generous. Right now, you've got people who are essentially retiring on $21,000 a year in 2024 if they're getting the average Social Security benefit. Unfortunately, the other reality is that half of Americans at any given point do not have access to an employer-sponsored pension to help supplement Social Security as was intended. Unfortunately, the private savings piece that was supposed to be the third leg of the stool has sort of become the 401k. And for the people who don't have access to an employer pension, they've got just Social Security. So you've got about 60% of people that are looking at Social Security as one of their only sources of retirement. So I get concerned about anything that would start to reduce Social Security benefits for these folks, particularly anything blunt. The retirement age increase is a very blunt tool. It affects everybody equally when we know that longevity increases have not been equally distributed across the distribution. Higher earners are living longer than lower earners. Punishing your lower earners by saying you now are going to take a 40% cut instead of 30%, to me, isn't helping the people that are going to rely on the program the most. So I do think more about the revenue side. I think something that maybe a lot of people don't know is that unlike the HI program that does not have a cap on the payroll tax, Social Security does. Social Security right now has about $168,000 that is the maximum upon which anyone is going to pay the Social Security tax. It also caps the benefits that people might receive from those contributions. I think, frankly, it's time to look at that cap because as a percentage of total earnings in the United States, that has been shrinking over time, predominantly due to the difference in growth, where you have your higher earner growth outpacing the wages of the lower earners. And so we're only capturing 82% or so of earnings in the economy. So removing the cap, providing a progressive additional portion of the benefit formula so that there remains a connection between what people contribute and what they receive from the program, to me, is a natural first step. It addresses the erosion of the tax base for the program that everyone acknowledges has been happening for decades, unfortunately, due to that disparity in income. The other thing I'd want to look at is something that also erodes the tax base, and that is the shift of compensation from wages into additional fringe benefits. A huge portion of total compensation now is used for paying for health insurance for workers, or for cafeteria plans like paying for daycare. The two tiers, the two highest income tiers in the United States are the ones that are benefiting from those benefits being part of a tax code that rewards workers for providing those benefits. We should start talking about compensation as a whole instead of just wages, because these are, frankly, we use the term in kind when it comes to SSI. These are in-kind wages, and I think we need to start thinking of them that way.
So Marc, I want to add something on this because you gave Laura the fun stuff. I'm the tax economist and you gave her the tax questions. So what I think is important, and again, think about this as a cafeteria of options, like with revenues and cost issues. Laura's right that we have to be careful about how any changes we do impact the lower lifetime earners and those who really depend on this program. I think we all kind of agree on that. We also need to think more holistically about the economics of this. You can't just keep taxing people and expect them to work and pay. And if we wait until 2033 and just do this on payroll tax rates, not talking about anything else, just the rates, they go up by 4 percentage points. You get to the point where payroll taxes, when you include Medicare, which we haven't added into any Medicare tax increases, will be hitting about 20%. Add in federal, add in state, and all of a sudden you're working for 50 cents in the dollar. People start changing their compensation behavior, as Laura mentioned, going to fringe benefits, perhaps maybe capital gains. This all changes. And so I think we need to think more holistically, because the payroll tax alone is a very big disincentive to work, both for the employer and for the employee. So even though there's been this link historically between payroll taxes and your benefits as an earned benefit, it might be time to rethink what this means and find alternate sources of revenues for the Social Security program, which could be anything from, again, taxing fringe benefits, doing a carbon tax, doing a financial transaction tax. I'm not endorsing one over the other, but I am concerned that the more and more we tax labor, the less labor is going to be basically marketable for employers and employees, and that'll just create a downward spiral on productivity and something else. So I want us to think more holistically about how we do this than just myopically focusing on maybe raising the retirement age or raising the tax rate or the tax backs. And we can do a combination, right? So we can think about this as a cafeteria menu option.
And if I can just jump onto that for a second, because I know we're concerned about growth, but you know, a 20% reduction or a 17% reduction in benefits, to think that that is not going to have an impact on the macroeconomic situation that we find ourselves in. Sorry, it is, Social Security is a stabilizing program in the same way that the unemployment insurance program is. And the people who are getting Social Security benefits, I guarantee you, are spending most of those dollars. They're not setting them aside. They're going back into the economy. And so we do need to think about, when it comes to growth, not just does a tax increase have an effect on growth, but what do the benefit cut possibilities do to growth?
Well, that's, I think, a good segue to talk a little bit about the politics of this. Can I just see a sort of a show of hands? How many of you think that Congress is going to act prior to a year before any of the trust fund deadlines to address HI or Social Security? No hands are up. Okay. Oh, wait. Michael does. Great. That's the optimism I didn't expect, but yeah, go.
You had such a high bar there, Marc, 1 year before depletion. So sure, if you said 1 year from now, that's a very different question. I think that when I'll talk for Medicare, 10 years out is very different than 1 year out. So when they will act, how they will act, what they will do, I think is a little bit unclear. But I do think it's going to be, I do think that it's likely that there will be action before the year before depletion.
I'm so encouraged to hear that.
Maybe
Andrea,
that depends if the year before depletion is an election year, some version of that, right? Like sort that yourself.
What are some of the, and Andrea, I'm kind of pointing to you, but also to Michael, are there some low-hanging fruit out there in the Medicare space where there already really is bipartisan agreement and we could, get some singles and doubles.
Yeah, I mean, I think that there are there is low-hanging fruit around MA overpayments. I mean, I think that there's been a lot of welcome and important scrutiny there. So I really do think that is an area for movement well prior to 1 year before deflation, taking Michael's point. I also think, and this actually gets back to a point that Laura made about when you're looking at total compensation and how much of that in the employer space, right, is eaten up by healthcare costs. One of the things that we haven't talked about, which is healthcare prices, how high they are, like both with respect to services, but also prescription drugs. One of the things that I think has been incredibly rewarding to see is Medicare's new ability to negotiate drug prices. So I think depending on the success of that, I mean, it'll be interesting to see what the final prices are later this summer. But if there's continued momentum there, I could see there being an opportunity to add additional drugs to that list. I think I'm eager to see whether in the coming years, some of these newer, very expensive and very wide-reaching drugs like the GLP-1s, right? If they wind up making that list and demonstrate another example of how you can simultaneously improve access to, in this case, prescription drugs, while also bringing down costs to the federal government, that just again creates more policy momentum to expand the reach of the negotiation program. So that could be another area as well.
So I don't know if you're going to ask me this question, Marc. If you want to, should I wait?
Sure, go
for you
ahead.
to ask? I think the way I think about this question is in two steps. The first one is what sector or what area you're going to focus in, Medicare Advantage, and then how quick and aggressive are you going to be? I do think there's a lot of understanding that Medicare Advantage has become much more generous relative to fee-for-service over time. And I think there is some sense that some changes there would be necessary. In fact, you've seen some even in the trustees report, how they've done with the benchmark. There's been some changes to current law that have given some of the extension. And I think you'll see some of that. The question is sort of how aggressive to be. The same, by the way, is true with drugs. The trade-off has to do with innovation and how you think that's going to play out. And I think in both of those cases, the advantage of working sooner rather than later is you can be more modest in your actions. You can see what is gained and what is lost. You can be a little bit more deliberative in what's happening. And I think that's the real issue with a lot of those things. The other thing that I would say, and I'll focus on the Medicare Advantage space here, but there's other areas like site neutral payments would be an example where independent of whether you're trying to save money, the payment models themselves may in fact encourage something you want. So in the case of Medicare Advantage, it's not simply that coding or selection raises spending relative to fee-for-service. It creates an imbalance even within the Medicare Advantage program because there's just heterogeneity across plans in the coding and selection. So you might say, let's just try and, Andrea mentioned some of the favorites, chart reviews, health risk assessment things, there's others. You might think it's wise to tighten up some of those things simply to improve the way the program is designed now, as opposed to trying to simply save money. The same could be true in some choice support, site neutral payments I mentioned. There's just a lot of nooks and crannies in the Medicare program. And I guess to the people listening, I would say, it is fine to try and find a home run, one and done solution. And I won't speak to that in the Social Security context because frankly, I have no idea. But in the Medicare context, I think this is going to be much more a sequence of somewhat smaller, ideally titrated policies to both try and improve efficiency and hopefully save some money. There are going to be things like how we improve the alternative payment model system. And I think at the end of the day, the big success is that we can develop payment models, be it them in MA or ACOs or bundle payment models, you pick, I have my preferences, that can encourage the delivery system to deliver care more efficiently. And if we can do that in a way that doesn't have a crushing administrative burden on providers. And I am hopeful that some of the new technologies that don't fit well into fee-for-service, consider artificial intelligence, will be able to find a home in some of these other payment models, and that efficiency will help us continue a slowdown in medical spending growth that makes the current report seem pessimistic relative to what we can ultimately do if we can improve our payment models.
Thanks. So we're running out of time, but a lot of people ask some version of the question, why is this so politically hard? How do we find solutions, et cetera? So I'm going to go down the line and ask you sort of a related question. I'd like a really short answers, so we don't all get kicked out of the Zoom. But if there was one thing that you wish that members of Congress understood that you think would help sort of make this easier that they don't understand now, what would that be? And let's go Andrea, Laura, Jason, Michael, since that's where you are on my Zoom screens.
That's such a good question. I mean, I think, and again, I'm only going to speak to Medicare. I'm not a Social Security expert, but what I have found in talking to members and, even talking to policy folks in particular, is that one of the challenging things about this is, like, the healthcare system and Medicare too, it's pretty complex. It's not, it's not intuitive unless you're in it, unless you've actually experienced being a beneficiary, making the choice. Like, it's hard to wrap your arms around the totality of policy options. So I actually find that I spend a fair amount of time at the outset talking with them about, like, do you understand the difference between these two, between traditional Medicare and Medicare Advantage? Do you understand how these look? Do you understand? And often the answer is no, right? And so we sort of walk through that. So there's a little bit of a just demystifying or making the totality of the system a little bit less complex. So there's that. I mean, that's not it's a funny answer, but it's a real answer. Like, it is actually fascinating what that hurdle looks like. But apart from that, on the why is it so politically hard, right? This is a lot of money. This is a huge source of revenue for some pretty gigantic players, both on the provider side and on the payer side. So, I mean, not to mention, doing something like being able to negotiate the prices of 10 drugs is politically really challenging too, because that's a lot of money for pharmaceutical companies. So I think that's why it's so hard, right? You're tapping into potential revenue sources.
Laura.
And compared to Medicare, Social Security is a lot easier because we don't have those external pressures. So I give you all kudos. I think one thing that I used to give a lot of briefings on the Hill to members. And I think one thing that they tended to forget is that Social Security is an insurance program, and they remember the retirement side of it, but they forget that there is a disability insurance component to it. And they forget that there is a spousal and survivor portion to it. And frankly, if you go out into the world and you ask an insurance company to provide a parallel disability insurance plan to what is available through Social Security, they will tell you they can't do it. It is not financially feasible. So when people start looking at solutions, they forget about what the effect is going to be on the disability side of the program. And they come back to that and they think, oh, well, we'll just deal with that later. We'll make some tweaks. We'll connect it. We'll deal with that later. You can't. It's too big of an important part of the program, and it's inherently connected to the idea of social insurance overall. So politically, these guys have a tough job in terms of politics. Math is easy, politics are hard. That's why I do math.
Jason?
So I think I would add, 'cause I know our time is short. It's politicians don't get rewarded right now for fiscal responsibility. They get rewarded for cutting taxes or giving more benefits out. And it's hard to make those two match. And I think the lesson I would say here, and the caution I would put out, is that there is no such thing as a free lunch. Everything has costs, including delaying making a decision has costs. And my fear right now is I've been talking about this for 15 plus years, ever since I was at Social Security, and we really haven't made any changes. And we talk to retirement planners all the time, and they're worried about inflation risk and sequence of return risk and market risk. We've now got to talk about political risk. Who's going to be in the White House in 2033? Who's going to be running Congress in 2033? Is the bond market going to allow us to keep issuing debt? Is that going to force our hand? And my concern is that if we don't do something on our own, the markets are going to force us to do something instead. And that will probably not be to our advantage. It means there's probably going to be some additional taxes, benefit cuts, and probably higher interest payments along the way. So we are in our best interest to try to find the political courage to do something now.
Michael, last word?
Yeah, I was hoping to get cut off. So plus one to Jason's comment on trade-offs, and I would just add, there's not in Medicare space, there's not going to be an easy, everybody's happy solution like prevention's going to get us out of this problem. There are going to be choices that are going to have to be made, and we need to think through what those choices are. And I think last point is we are going to therefore need payment models and systems that encourage the delivery system, and that's ultimately what we care about, to find and exploit efficiencies in care delivery, because that's ultimately what is going to be needed.
Well, thank you, all of you, so much. Chris Rotella, I think, is going to jump back on to give everybody the final logistics, but please, I know they won't be able to hear your applause, but go ahead and give my panelists a huge round of applause. If you're loud enough, maybe hear it out the window. Thank you all.
Yes, thank you so much, everyone, for joining us on this panel. Thank you for everybody who logged in. We had so many people and so many questions. For those of you interested, we're going to be posting this recording on our website, crfb.org, either later today or tomorrow, along with the slides. And you can find all of the information that Marc and the different panelists have spoken about, including the papers that we published yesterday and this morning on the trustees reports, all on our website, crfb.org. Thank you so much, and we look forward to welcoming you at a future virtual or in-person event.